All right, I'll quit being silly. So what I wanted to go through with this talk, and I just am kicking myself now that Ariel mentioned survival with treatment effects, because that would have been such a cool addition to this, but I don't know how we're going to squeeze that in. Next time, we'll do it next time. So all of these are sort of variations on what we just talked about for more sophisticated scenarios. So time varying covariates. Sometimes we have variables, covariates, that are not fixed, like sex, generally fixed over time or whatever. We may have things that vary, and so we want to take that into account in our modeling. Shared frailty, I'll define what that is. And shared frailty sort of leads us into multi-level. What if we have patients nested within physician practices and things like that? You can even now incorporate survival analysis into full-blown structural equation models if you do that sort of thing. And then we'll wrap up talking about competing risks. What if you have things, if you're interested in one event, there are other events that compete with that. So we'll just kind of touch on that at the end. Just in case there are people here that weren't here for the first talk, I will be referring to almost everything that we're going to talk about in here is in this book. This one's an intro to survival analysis. So there's not a whole lot on, for instance, competing risks. It just kind of gives you a little intro. The other thing I want to apologize for with this talk is that I didn't have one good data set that worked for all of these scenarios. So I'm going to be bouncing around data sets in this talk, and that's frustrating, but it's just the nature of the different kinds of data sets. So the first one we're going to take a look at is this STAN3 data set. It's a Stanford heart surgery data set. We have an ID variable. We have the patient's age. We have whether they died or not, their survival status. We have their survival time. This time it's measured in days. That's why I keep getting confused between years and days. And then they have this surgery, CABG, coronary artery bypass graft or something. CABG, it's popular surgery evidently for this. And then we have a variable called transplant, which is whether or not the person got a heart transplant and whether or not the time interval is post-transplant or not, because we want to know when they got the transplant, so to speak. And then we also have this T1 variable, which I'm blanking on what that is. Oh, that's the time variable. That's important, right? No, we have survival time as well in days. We'll come back and see that. Why do I have T1 in here? I think that's the end of the interval. Anyway, part of what I want to show you with this data set is person one, we only have one row for person one set of data, so to speak. Person two, we have one set of data, but person three, we actually have two entries in this data set for person three. And why is that? Person four, we have two entries. So what we're going to do is we're going to ST set our data. T1 is actually the time variable we're going to be using. That's why it's there. And then we also have whether or not they failed. Died is the failure variable. But we also this time have an option for ID. ID is telling Stata, hey, anybody with the same ID, that's the same person. So keep those bundled together. Even though they're on different rows, we need to keep them together. So after I ST set the data, let's take a look at person 10. Person 10 has two entries here. I'm eventually going to trip on these cables. Person 10 has two entries. Their time zero, this underscore time zero variable that ST set creates, person 10 starts at time zero and we follow them to time 12. T1 is 12. They were not dead. They were censored at time 12. And this post-tran variable, whether it was post-transplant, whether they had a heart transplant, let me move over here so everybody can see. This post-transplant indicator has changed from one time interval to the next. So the person was not post-transplant, heart transplant, at the interval 0 to 12. But in the interval 12 to 58 days, they had a transplant for that time. So that's what we mean by a time-varying covariate. The post-transplant variable, heart transplant, changed while we were following this person, and we'd like to take that into account. Same thing with person 11. For the first 26 days, this person did not have a heart transplant, but from time 26 to 153, they did have a heart transplant. Up until time 26, we know that they were censored, but they did have the event out of day 153. So this becomes a little bit more complicated. We have multiple rows in our data set now for each person, and that's the first thing we need to deal with is how do we even ST set our data? Yes.
Real quick, so in terms of coding, like if they had it at their first time point, would it be 1, 1, like 1, and then thereafter it's 1? Or does that mean that it occurred? You know what I mean? Like I had a transplant during 12 days. I still have that transplant for the remaining.
Then it would be 1, 1 here.
Okay.
But in that case, unless you had another time varying covariate, there wouldn't be any reason to code them as 1 and 1. But you might, if you had another variable that is changing, this could be 1 and 1. So yeah, that's a perfectly reasonable thing to do as well. Here I'm focusing in just on that post-tran variable, but you could have other time varying covariates. Here I've only shown you the ones that changed over time. I don't really like the way I did this graph because I don't know if this should be censored or that's the time that they have the post-transplant. But if you imagine this graphically over time, we follow them for a certain amount of time and they're censored up to here because they haven't had the event yet prior to having that transplant. Then we follow them the rest of the time and then they do eventually die. So that's how I would represent these graphically, just the raw data. Not everyone does this. I just like doing that with the data just to kind of get a feel for it. And it's nice for presentations and things too. So now, if I fit a Cox model, the famous Cox model with time-dependent covariates, because of the way I've ST set my data, all I have to do is use my Cox command like I did before, and Stata will take that into account. That's it. That's all I have to do. Because what it's going to do is for that first interval of time, it's going to treat the covariate as being 0. And for the next interval of time, it'll treat it as 1. It will take into account that they were censored or died or whatever. All of that machinery is just built right into Stata, and that's all you have to do. So you just treat it like any other variable. And then you can interpret the hazard ratio just like either having the transplant or not having the transplant. You know, it doesn't seem to have any effect in this case. So for categorical time-varying covariates, this is pretty simple and straightforward. We can look at the predictions from this. It looks like having the, what is this, surgery. Surgery in this case seems to be pretty beneficial because these people are living a lot longer. Okay? Just things you can do after the Cox model. Continuous time-varying covariates are a little more tricky though. So let's take a look at this. We actually have to use yet a different data set. This one is HIP data. It's another kind of somewhat famous data set in the survival analysis literature. So again, we have ID, we have the beginning. Here we have 2 time variables, time 0 and time 1. Time 0, the other thing I want to show you is different kinds of data you're likely to encounter, and this is another one. Here we know the beginning of the span. We have separate time variables for beginning and end. And we also know whether or not the patient had a hip fracture or not. That's the event of interest, so they're not dying this time. We're following them until they have a hip fracture or not. We know their age at the enrollment. We know their calcium levels, which actually in this case is going to be varying. We also know their initial drug level of some drug that they've been getting. And I want to talk about these two as 2 different kinds of time-varying covariates. So first off, how do we get this data in? This is what just the main part of the data look like. So instead of having a single time variable, we have 2. So I have the ID, I have time 0, I have time 1, and then I have whether or not they experienced the fracture or not. And just with the raw data, I can tell patient 9 was followed for time 0 to 5, and then again from 5 to 8. And there are other things, and I'll show you why they're split into 2 later, but that's what we're going to need to ST set our data. So here we're going to type ST set. Time 1 is the ending time. So the syntax is going to be ST set, the ending time, followed by a comma, and then we need to specify the ID because we have multiple record data again. So we're going to have to tell Stata the ID variable. Then we need to tell it the failure variable, which is fracture, do they have the fracture or not. And now there's another option called time 0, which ironically enough, or maybe conveniently enough, is also time 0 in our data set. But that tells Stata what the beginning time is. Time 0 doesn't have to be 0. It could be 5 or something else. There may be a reason why you want to start at a different time other than 0. If you don't specify, Stata is going to assume that that time started at 0. But if you wanted to, you could actually move that around using this time 0. So now let's take a look at what Stata did with our once. Sure, yes.
Is that time 0 something that could be like somebody's age? Is that an actual variable that you can change for each individual, or is that
yes.
Time? Okay,
it's a time you can specify for each person. And it could be 0 for everyone except a couple of people for whatever reason. Good question. All right, so these are those underscore variables that Stata created. So now time 0 and time 1 became underscore time 0 and underscore time t, which is actually what Stata wanted all along. The reason this is important here is because time 0 for this row of data, time 0 is not 0, it's 5. So this interval is 5 to 8, whereas this interval is 0 to 5. That's what happens when you have multi-record data. And this occurs a lot when you have time-varying covariates because their covariates are changing over time. So one interval while you're following them, they are in one state, treated, controlled, whatever. but in another time interval, they may not be. So we're going to have these multi-records, and there's no reason you couldn't have 3 or 4 or 5 rows for the same person like this.
And they don't have to be equally spaced out either.
Right, they don't have to be equally spaced, and they don't not across people or anything. It's just whatever the time, start time and end time for that particular interval is. And you can have gaps. Boy, I shouldn't have even said that, but because it opens up a whole world of complications. But it is possible to deal with gaps as well. So if this was 0 to 5 and this was 9 to 12, you can actually have gaps. But let's just not even go there. That's a whole other complication. So time varying covariates. Let's look at these two. First, I have calcium. So calcium level for patient 9, calcium levels were different for the 2 intervals. So it was measured sometime, I guess, in the first interval, first 5, what is this, days? I forget the, anyway. Calcium is changing over time, and we'd like to take that into account in our analysis, that during this interval it's one thing, and during the other interval it's different. Initial drug level doesn't appear to be time varying. They're the same across all of these. But in this particular data set, initial drug level, the drug has a half-life, I think, of 2 days, this particular drug that they were given. And so the level of the drug is not constant throughout the entire interval. So even though it starts, the numbers look the same, the person who is modeling this would like to be able to take that into account, the fact that the drug is decreasing over time. So let's look at these two separately. One is very explicitly time varying. The other one is functionally time varying. Let's look at calcium first. If it's just plain old garden variety time varying and it's continuous, and you want to treat it as continuous, the command is just stcox age, and then the option is TVC, which is time varying covariate, calcium, and Stata will then take that into account. So what it's going to do is it's going to, for the interval for patient 9, for the first interval, it's going to use this value as the covariate for calcium. And then for the interval 5 through 8, it's going to use this value, 9.18, for the value of calcium. So it's just going to change what the covariate level is in the analysis. Okay. So that one's fairly straightforward, but you do need to put those time varying covariates in the option TVC so Stata knows to change that and not just use the first occurrence of it. Okay. The second one is a little more complicated, initial drug level. Here I'm still going to specify TVC as an option, time varying covariate, because it's time varying. But I want to specify a functional form for how that thing is varying. Remember, if I go back and look at the raw data, it's the same. They got a dose of 50, whatever, milligrams or whatever, and I got another dose of 50 milligrams. But I want to allow for the fact that it has a half-life of 2 days. I can do that in my command by typing T. First off, I've specified that it's time varying. The second option is TEXP. That's an expression, a time expression. And what that does is tell Stata, I want to give it a functional form of its decay or increase or whatever. So I can actually specify that this thing is decreasing. If you calculate it, that would be a exponent for a half-life of 2 days. So if I assume that the drug has a half-life of 2 days, every 2 days its level is decreasing by half, I can specify a functional form for that and incorporate that into my model as well. So I don't actually have to have the values of the time varying covariates. I could specify a functional form and say, here's where it started, here's how it's changing functionally, and Stata will incorporate that as well into your analysis.
So if you do not do that, how does it treat that?
Excellent question. I don't pay him to ask these. The difference between these two, and that's what I was about to say, is here calcium is treated as constant through the entire interval, and there is a perfectly abrupt change at each interval. So let's say that it changed from 9.75 to 9.18. There is no allowance in the analysis for a subtle, slow change, or I was on the drug yesterday, but it washed out a little, and I took some more, and it's stronger today and less tomorrow. It assumes perfect, even distribution of those covariates over that interval. So, which may not reflect reality at all. There may be sort of this washout effect or a peak effect right after you take the drug, followed by something else, which is why we have this T expression, time expression. It allows you to take into account that there may be a peak right after you take something and a fall off like a half-life or something like that. Because if you don't, it assumes it's perfectly uniform, whatever that covariate is, continues to vary over time with an abrupt shift at that time point. And that may or may not be realistic. swear I don't pay him to ask this. Okay, so that's time varying covariates. Any questions about that? It seems really mysterious, and I guess if you pick up books and you see a blizzard of equations, it sort of is, but it sort of isn't either. It's just the notion that you break it up. The hard part of dealing with it, truthfully, in real life, is dealing with the data sets where you have multiple records per person. And here we have 2, and it's pretty simple example data, but in real life, these things can get really messy. Because what happens if you have 5 rows for one person and 2 of these are missing? Then what do I do with that? Real life is way more messy than textbooks.
Question?
Yes.
So in this example, is this interval censored? Because the fracture occurs between 5 and 8, or does it assume that the fracture is occurring at time 1 or time 0?
Well, interval censored. I guess you would see it that way. I hadn't really thought about it, but the censoring does occur in an interval. Although in this case, it's at the end of a particular time period. But in the grand scheme of the whole person's experience, I suppose it is sort of interval censored. I hadn't really given it much thought, but that's a good point. Because they're censored. For this particular interval, it's the end of the interval. But from 0 to 8, the whole time that we followed patient 9, that is a censoring in the middle. So they hadn't had the event up to that time point. I'm not sure it's an important distinction, but yeah, I guess you could call it that particular censoring event interval because this fracture is saying that they were censored at that time. So I suppose it is a sort of interval censoring. Okay, any other questions about time varying covariates?
So you can have as many time varying covariates in the one as you want.
In theory, yes. There's nothing in the software that's going to prevent you from doing that. Now, the one thing that's not obvious since you asked that question is exactly I don't know how you would specify different TEXP for each of the different time varying covariates. There's probably an option to deal with that, and I just don't know what it is off the top of my head. That would be an excellent question. But if you just had garden variety time varying covariates and you didn't want to specify functional forms of the decay or anything like that, then yeah, you could put as many of those as you want.
Is there a difference between time varying covariate and like time varying hazard ratio or coefficients in the specification?
I'm not sure I understand that. Does it change?
So here for the initial drug level, by making it TBC,
Yes.
interacting it with that function of time,
Yes.
are we actually saying that it's varying over time, or are we just modeling the hazard ratio as a function of time?
No, we're actually saying that the covariate is changing over time. So in the likelihood function and the calculations, the over time, say this interval, let's go back to here. Let's say that person 9, during this interval, if the half-life is every 2 days, the drug is reduced by half. The functional form and the likelihood function that's being calculated on the background under the hood, from days 0 and 1, the drug level, covariate level would be 50. For 2, I guess day 2, it would be 25. It would be half that. And you'd have to do the functional form, whatever that exponent works out to be. But the covariate at each point in time would be slightly different in the calculation, as opposed to being fixed for the entire 5-day span or year, whatever these days are measured as. Am I answering your question? Yeah, it's just changing what the level of the covariate is over time. And that TEXP option allows you to specify a functional form for that as opposed to. I think there's a way where you can actually tell at certain levels. It's a pretty flexible option in terms of the kinds of functions you can put in there. So anyway. All right, so let's move on to shared frailty models. And we're going to talk about this both for Cox and for parametric. There are 4 different ways in Stata, and I discovered one that I wasn't aware of while I was putting this talk together. So you can do shared frailty models with Cox regression, and I went ahead and put this in just so you know what the differences are. Cox regression is going to assume a gamma distribution for the shared frailty, and I'll come back and define what this is shortly. But Cox is going to assume gamma. There's the parametric regression, the ST-reg family of commands. That's going to assume either gamma or inverse Gaussian frailty. And you can specify panel data. This one, I shouldn't say this in a recording, but I forgot there even was an XT-ST-reg command for the economists. That assumes normal shared frailty And then there's multi-level parametric, which is in the ST reg, which leads us into the next section. That is another kind of shared frailty, which also assumes normal shared frailty. There's an individual frailty. I didn't want to spend any time on that, given limits of time. These are shared frailty. There are unshared frailties. So if you want to deal with heteroscedasticity and things like that, you can deal with that as a frailty as well, whereas each individual is kind of treated as their own unit. What these are for is what happens if I have, this is the data set we're going to be looking at. It's another famous one called the catheter data set. These data, I hate reading slides, but I can't remember all this. These data are from a study of 38 kidney dialysis patients as described in this paper. The study is concerned with the prevalence of infection at the catheter insertion point. 2 recurrence times and days are measured for each patient, and each recorded time is the time from the initial insertion. And they either get an infection or they're censored. So the outcome of interest is whether they got an infection or not. What's unique is that we do this twice with each of the patients. So if I look at the raw data, patient 1 is seen twice. They have a 0 to 16, and then we follow them again, another insertion point, and we follow them for 8 days. In this case, both of these had an infection. Okay. In this case, we saw patient 2 twice, and one time they did not have an infection, the second time they did. These are not like the time-varying covariance data where we had intervals. In fact, let's ST set these and see what it looks like. So I've ST set the data. Time is the time to the event. Failure is the infection. And so now if I look at my T0 and T here, patient 1 has an interval of 0 to 16, and they had the event, an infection. And then patient 1 has another T0 to T, which is 0 to 8. It's not 0 to 16 and then 17 to something else like it was with time-varying covariance. These are 2 separate intervals of time. So it's kind of like multi-level data. In fact, this is a perfect segue into multi-level data, but in the old days, it was called frailty models, and it was 2 levels only. But here we have 2 different survival experiences or event histories for the same person. And because it's the same person, there's almost certainly correlation between those events for the same person or time to event for the same person. So if I wanted to run this with a Cox model, I would just type ST Cox age female if I'm interested in those covariates, and then just type comma shared patient, and Stata will adjust the standard errors for the fact that you have essentially multi-level, 2-level type data. Frailty. What you're assuming is that there's some patient-specific effect that's common to both of those times that we followed this patient. Okay? It's almost strange to put this section in and not just jump right on into multi-level, but in the history of this and in the survival literature, you'll see these often still called frailty models because that's just how they historically have been modeled. Okay? So we would interpret these hazard ratios just like we did before. It's just that we have to adjust our standard errors, and we can do this ST curves after and see that females are having a longer time to infection than the males. Yeah.
Just a quick clarification.
Yes.
The 2 time points, are those 2 distinct time points, and we're not concerned with how they're ordered in relation to each other?
Yes, that's how it's treated here. Now, that may be an important thing, and I'm not sure off the top of my head how you would go about modeling that if having done it once changes what happens the next time. So you're right, here I've treated the first interval 0 to 16 and 0 to 8 as though they're arbitrary. I don't know which one came first. Maybe the second one was the first time they did it, and the 0 to 16 was the second. I don't know. And if there was an ordering effect, boy, that would be a whole other thing you'd have to take into account in your model. Because maybe they've become more experienced inserting the catheter if they're doing it themselves, so they're more likely to have an infection the first or second time they do it. But third or fourth, they've gotten better, and yeah, that's a good thing you want to take into account. You just have to think about how to do that. So that's Cox models. Parametric regression, like we did in the end of the last talk, this we're going to have to assume a functional form for our hazard function. But it's the same idea. I'm going to use ST-reg. Here I've used I-dot in front of female because I like to do some margin stuff. I-dot is a Stata shorthand for telling Stata that female is an indicator variable or it's categorical variable. And the reason I did it here is I want to do some stuff with margins after. But the syntax is going to be I still have to specify a distributional form, a functional form for my hazard rate. And then the frailty, I could specify here either gamma or inverse Gaussian. Just two different functional forms for how I want to take that sort of account for that correlation in my data. And then I still have the shared option patient. So that's saying that the patients in my data set have some shared patient effect that I want to take into account. No log just tells Stata to suppress the log likelihood, the iteration history. Again, we can sort of ignore this part at the bottom for the most part. The main thing we're interested in here is still the hazard ratios. Note that we do get an intercept again, and we would interpret these just the same way we did before. Okay? But we have accounted for the fact that we have correlated data. Like we did before, we can plot hazard functions for these, and they're nice and smooth, again, because we're using a parametric model, fully parametric model. So we get these nice, smooth survival curves after. But they're model-based. It's not like Kaplan-Meier where it's raw data. Now, I could use the margins command after this if I wanted to look at predictions. So these are my predicted times, median time to, what was this one? Infections. That's why I hate changing data sets, because, okay, this is time to infection. So here we can see the females are having a longer time to infection than the males are, on average, predicted from my model. XT-ST-reg. I had forgotten this was even in there. In Stata, XT is for cross-sectional panel data. It's kind of econometric speak for what other folks call longitudinal data. Anyway, there is a command called XT-ST-reg that will allow you to do this. Not only do you have to ST set your data first to do this, but you also have to XT set your data. And what that's going to do is tell Stata in advance, patient is the nesting variable. That's the variable that groups all of the clusters together. So once I've XT set my data, I just type XT set patient, then I don't have to do that with XT-XT-reg. I can just run this over and over, and because I've XT set it, Stata knows, and I can just run XT-ST-reg over and over. So it looks a lot like the parametric version, ST-reg. I still have to specify a functional form for the hazard function, excuse me. And again, we get very similar looking hazard ratios to what we did before. Lastly, and leading into the next section, we could just go ahead and use the new MEST-reg command. In Stata 14, or 13, I'm blanking now, we introduced truly multi-level survival analysis. So rather than just doing frailty models, which at best is two levels of nesting by patient, you could do true multi-level survival models. So if you had repeated observations within patient, but those patients were treated by the same physician, there could be a physician level effect as well. So MEST-reg allows you to, now I'm giving away the next section. But because of that, we could actually use the MEST-reg command as an option or an alternative to a frailty model. Okay? So this is sort of the state-of-the-art command now. You would specify the frailty here by just putting the double bar in and then putting patient colon. So Stata knows that that's what the nesting structure is. We still have to specify a distributional form because this is parametric regression. So I'm going to assume an exponential function for my hazard function. And again, I get my hazard ratio, and it looks pretty much like the other results. So if I actually gather up all my estimates and put them in a single table, these are my estimates for my Cox model for age and sex, age and female. And then these, ignoring the constants, are the results for ST-reg, XT-ST-reg, and multi-level ST-reg. And you notice that they look almost identical, with the exception of these two have slightly smaller hazard ratios for female. And I'm not sure if that's because of the functional form. I think it has to do with whether you assume a gamma frailty or whether you assume inverse Gaussian or whatever. XT-ST-reg and MEST-reg are going to be the same because they're functionally the same. They're both using assuming normal frailties as opposed to gamma or something else. So in this particular case, the results look pretty similar. The only reason I would suggest at this point to using one of the others, ST-reg or Cox, is if you intentionally want to use these gamma frailties, but you could even incorporate that into MEST-reg. So I hate to say that we've made the other commands obsolete, certainly not with Cox, but MEST-reg is now sort of the state-of-the-art frailty multi-level survival model in Stata. Okay.
That makes sense when you're talking about your multiple outcome events, right? So you're saying at the next level up, if you let the patient, let the events occur within patients, and then the whole timing of that, of follow-up, the multiple differences in time are taken into account and letting them vary on their own. I mean, you basically solve the problem.
Yeah.
Solve the problem you would have as opposed to on a regular modeling where you're just assuming there's a straight line that you're drawing the fixed effects across everybody.
Right. Yeah. The one thing I don't think you can do with MEST reg is the inverse Gaussian. I don't know that you can do. I'd have to think about that. But MEST reg is probably the state of the art these days. So if you wanted to do the gamma frailties or the inverse Gaussian, you might want to back up and do ST reg. But anyway. So multi-level survival analysis, what do we mean by that? Well, up to this point, we just considered repeated episodes within patient. But what if we wanted to take a third or a fourth level into account? Maybe there's a physician effect. Maybe they go to a different class to learn how to insert these catheters. And one instructor is very good at teaching it and others not. Point being, there's another level that you potentially need to account for. We can do this now by incorporating full-blown random effects into MEST reg. Now, these are only parametric models. Can't do this with Cox. So you are going to have to specify a functional form for your hazard functions, okay? But again, sometimes that's really worth the extra effort to come up with what that is, to come up with a good way of modeling that. So the rest of the model looks much like a mixed effects logistic regression model. The data set that I'm going to use here is simulated because I couldn't find a really good multi-level simulated data set. And turns out to be an interesting exercise simulating multi-level survival data, parametric survival data. So if you're interested in that, I'm happy to pass around. I'm not certain I've done it exactly right, but it works pretty well. So these are simulated data. I'm going to assume that I have seizures. Let's say that I follow patients between seizures. So I follow them for a while after a visit, see if they have an epileptic seizure or not. And I have repeated episodes. This is nested within patient, obviously. I have repeated episodes within patient. And then maybe I want to take into account that there's a physician effect. So I have a physician ID, a patient ID, an episode, and I have the age at diagnosis when the person was diagnosed with epilepsy. I have their sex, I have the time until they have their seizure, and then I have an indicator for seizure. So I'm going to ST set, this is just a quick listing of the raw data. And when I simulated these, I intentionally made different numbers of groups for each person because otherwise it's perfectly balanced, and that's no fun. So there are two repeated observations for patient 4, nested within physician 1. There are 5 of these for patient 5, 3 for 6, and so forth. So my point being is you don't have to have perfectly balanced groups for this to work. You may have 5 repeated observations for one patient and 3 for another. So I'm going to ST set my data just like I did before. Time, seizure, I have scale equals 1 again just because it's a habit. So the command then is MEST reg. And if you've used any of Stata's other multi-level modeling commands, this syntax should look really familiar. It's the same old double bar with the nesting variables followed by a colon. So here I have 2 vertical bars, physician colon, and then 2 vertical bars and patient colon. That ordering is important because that's telling Stata physician is the top level, patient is the next lowest level, and then the lowest level is whatever the individual observations are. We don't have to specify that explicitly. I need to specify the functional form of the hazard, which is in this case, I'm going to use exponential again because I created the data that way. And then when I fit the model, I actually get explicit, at the bottom of this, explicit estimates of the variance at each of these levels, which is kind of unique and kind of cool as well. So if you're interested in the relative variability at each of the levels, this is a nice thing to have in your output. Otherwise, if we want to focus on the top, we interpret our hazard ratios just the same way we did before. Okay. I'm running a little behind, so I better move along. Any questions on frailty and multi-level? They're really kind of the same thing, but the older jargon, I think, is still pretty prevalent. So, okay. Survival analysis and structural equation modeling. This is quick, but I just wanted to point this out. That in Stata 13, we introduced GSIM. 13, we introduced GSIM, but it was 14 before we added the survival functions to it. So that's why I'm thinking it's 14. As of Stata 14, you can now incorporate parametric survival models into a total structural equation model. Anybody do structural equation modeling in here? Okay, yeah, not many, only one, but so for your benefit, you can actually incorporate multi-level parametric survival models into a structural equation model, which is pretty cool if you do have that sort of time to event. Maybe you're not interested in survival. Maybe you're a teacher interested in time to mastery of a certain skill or something like that. It's a nice way to do incorporate this into that.
And I can vouch for it. It's a fabulous program. I love it.
The GSIM, yeah, it does a lot of cool stuff. It's actually the engine that a lot of things now run through Stata because so many things are special cases of GSIM that we don't have separate engines for everything. It just gets funneled through the GSIM engine. So the syntax is going to look a little bit different, but that's how we would run this exact same model that we ran before using MEST-reg. You can do the same thing with GSIM, and you're still going to get your variance estimates for each of the levels. So this is the equivalent command. The command looks a little bit more scary because we have these latent variables and you have to be a bit more explicit, but that is essentially the same command as that command right there in MEST-reg. And if you look at the results, they look pretty close to the same. Oh, these are the coefficients. If you want to see the exponentiating coefficients after GSIM, you actually have to type E-stat-E for them and it will exponentiate them for you. So you can see hazard ratios instead of coefficients. I'm going to move along because I want to get on to computing risk regression. Any questions about, and margins works after GSIM. So even after you fit these elaborate structural equation models, then you can still use margins to get predictions of your time to seizure or whatever it is that you're interested in. Okay, any questions? So competing risks regression. I'm actually a little nervous talking about this because this is not something I've ever done in real life, but it is something that you can do in Stata. The idea behind competing risk regression is exactly how it sounds. Someone's at my front door, sorry. Anybody have one of those Ring doorbells? My phone keeps going. They're really cool at first, and then they're annoying because every time someone comes to your door or the cat walks by, your phone goes off. So either the mailman's there or the cat just walked by. So competing risk regression. So maybe I'm interested in time to death, or let's say not time to death, time to heart attack, but something happens before the person has a heart attack that keeps me from observing them, the actual event that I'm interested in. That's called a competing risk. It's some other thing. The data set that we're going to look at is breast cancer. So I might be interested, the thing I'm interested in might be the recurrence of breast cancer, but it could have metastasized to another location. So I might be fine. They're going to have treatment for that other location. So that's going to screw up my entire study. So if I'm following this person, and they end up having what we're going to call a distant cancer, that's going to screw this up. And I'm not going to wait around until they have breast cancer to see. I'm going to go ahead and start treating them for the other thing. So distant cancer is a competing risk for the primary thing I'm interested in, which is recurrence of breast cancer. So now I have to start making this a little more complicated. So rather than talking about the hazard, I have to talk about a cause-specific hazard. So what's the hazard for having breast cancer recurrence? What's the hazard for having my competing risk? Before I treated these things as censored, and it's like they have this or they don't. But now I have this other thing that I would like to take into account somehow. And that adds a whole lot of complications. So if I write out my hazard now, it's the probability that the event occurs in that little sliver of time, remember when we were talking about hazards, and that it's failure from the cause I'm interested in. It could be local breast cancer, it could be distant metastasized cancer, and the time is greater than whatever time point I'm interested in. So now I have to talk about cause-specific hazards. So then the overall hazard rate is going to be the sum of all of these hazards. So the hazard for any of these things becomes the sum of these functions. And I can talk about once the failure does occur, it occurs with probability. It's the ratio of that cause-specific hazard relative to the total hazard. Then the next thing that's kind of unique to competing risk regression is something called the cumulative incidence function. So it's for cause I at time t. It's the probability of failing from cause I before up to whatever time I'm interested in. So I'm just writing this as the probability that they experience breast cancer recurrence at or before time t. So that's going to be the cumulative incidence function. So now we have to make this even more complicated. There's the subhazard function, which is failure per cause I for a particular cause. There's this average over the whole thing. The main thing we're interested in here is the cumulative incidence function. And I have different ones for different causes. And Fine and Gray, the guys that wrote this paper back in 1999, I think I'm saying this correctly, that essentially what we're going to do is analyze the data for each of the causes and kind of treat the other one as censored. That might not be perfectly technically correct, but that's kind of the way we're going to analyze these data. So let's look and see how we can use STCR-REG. So the first thing, the data set that I have here, I have age, the age at the start of the trial. I have whether or not they got some drug that I'm interested in. I have the person's race. I have the time and months until they have the event. And then I have a status variable. Status isn't just 1 or 0 anymore. It's 0, 1, or 2. So status equals 0 is censored. Status equals 1 is local relapse. That's breast cancer relapse. Status 2 is distant relapse, meaning metastasized cancer. So this is what just a quick listing of the drugs. Again, status 1 is local, status 2 is distant. So when I ST set my data, now instead of just typing failure status, I need to tell it specifically what's the thing, which kind of status is the risk I'm interested in. So status equals 1 is local relapse, so that's what I'm interested in. So if I ST set the data this way, I can then look at things like smooth hazards for, this is for local relapse, or I could ST set my data and tell it at status 2 is the failure of interest. So now distant relapse is the failure event I'm interested in. And I can look at the hazards for that over time. Essentially what we're doing with that is we're treating it 2 versus everything else or 1 versus everything else. So in that kind of a sense, you're treating it as though you have 2 separate, I have the event of interest versus censored and the other event of interest versus censored, but it's a way you can take that into account. If you want to actually calculate these cumulative incidence functions, though, you can use the STCR-REG command. And here you tell it what the competing status is. Remember, the STSet command, I told Stata, I'm interested in failure 1. Here I'm going to assume the thing I'm interested in is local relapse, but there's a competing event called status equals 2, excuse me, and it will take that into account and then compute these cumulative incidence functions. So this would be the competing risks or cumulative incidence for people by drug. This is for the local relapse is the primary event of interest. So this cumulative incidence means what's for, you have to say this carefully, for local breast cancer recurrence, what's the cumulative incidence over time? It's kind of the reverse of survival. Like if you flip this around, it's the survival function, but going the other direction. Now, nobody has it, but some people are having it, more people are having it. What's the cumulative incidence of this event over time? Taking into account the fact that I do have this other event, and it's taking that into account in the denominator when it calculates the incidence rate. This is not something for a 5-minute thing to talk.
How many competing risks is this? Is it only two categories, or can you put in more categories?
I think you can have multiple categories. I haven't played with this a whole lot, and I kind of deliberately cut this really short because this is its own talk. In fact, one of my colleagues used to run around doing a whole talk on this when it first came out, and it's even that squeezing this in. It's a much more complicated thing because you have these multiple events. Yeah. So I don't want to spend a lot of time going into detail, partly because I'm just not that familiar with it, but partly because it's its own whole huge topic. I just want you to know that it's available. It's something you can do, and if you want to know more about it, you definitely want to read the manual and pick up some books on this style of analysis because it really is kind of leaping off into a whole other world beyond these multi-level frailty things. So I think I'm almost out of time. Do we want to stop and take some questions, or anybody have any questions about this stuff? Thanks again for coming, by the way, if I don't get to thank you before you all run off. That's kind of early in the morning for this. Questions?